everybody said South Asians have lower risk factors and it's got to be something strange and weird and wonderful about them, maybe genes. But Prem Pius, then an associate professor at St. John's in India, and we did a small study. We had no RO1, no grant, nothing. I donated 3 of my honorarium, and we used that money to hire a research nurse, and we collected 200 first cases of acute MI and 280 sex match controls. And guess what? The biggest risk factor was smoking. Not LP little a, not your weird genes, and there's a dose responsibility. So more than 10 per day, it is 700% higher. Then fasting plasma glucose, just over 5, because it's a threshold that's even lower than diabetes, was important. Hypertension was important. Obesity, especially waist to hip ratio, which is the poor man's way of looking at fat distribution. Like Alka's MRI studies or something, fancy stuff, but it's the same concept, isn't it? And then the other thing people forget is low income is a risk factor. Every one of those has been described in non-South Asians. There's nothing different here. And vegetarian diet or non-vegetarian diet did not significantly increase the risk of cardiovascular disease, or at least MI. This is MI, not strokes. Now, in Canada, Sonia and I said, let's try to understand what's happening in Canada, and let's do some imaging stuff. So we studied 1,000 people, 300 South Asians, 300 Chinese, and 300 European Canadians. And we did B-mode ultrasound for atherosclerosis IMT thickness. And you will see that in all 3 groups, as the IMT increases, the prevalence of cardiovascular disease goes up. These numbers are flipped around. There was Mr. Microsoft was playing some games with me. So you can see in the Europeans it went up, and the Chinese it went up. So for the same level of atherosclerosis at this level, something was happening that we did not understand. And to this day, after investigating it for 20 years, I don't know why that is the case. Okay. Then, at that time, the global burden of disease papers came out, saying cardiovascular disease was the biggest cause of mortality in the world. It accounted for, in 1990, for 12 million deaths. When in 2013 it increased globally to 17 million. And so the change is a 40% change. Most of this change is because there were more people in the world. So, more disease. Part of the change, the biggest part of the change is because people were older. They were getting to this age when they would get cardiovascular disease. Once you adjusted for both of them, cardiovascular disease mortality came down 40%. In 23 years, that's what this is. Over that period, it came down by 40%. So news is not gloom and doom. South Asians don't have 4-fold increase in cardiovascular disease, and things are getting better. Now, most of the cardiovascular disease in the world is in low and middle income countries. Why? So we said, well, 80% of the world lives in poor countries, so 80% of the disease must be there. It's just a numbers game. Also, our risk factor is higher in poorer countries compared to high-income countries, so they get more disease. Is there a problem with healthcare, health systems? Are they weaker in these countries? And is access and affordability of care poorer in these countries? People laugh at me and say, why are you doing these studies in these poor countries? It doesn't matter to countries like Canada, the US, where we have good health care. My answer is, come on, give me a break. You have good health care in the US. So we did the inter-heart studies, where we did the case control study that we did in Bangalore, in 200 cases, 200 controls, in 28,000 people from 52 countries in every continent of the world. We wrote a bunch of grants, half of them were turned down, half got funded, but the biggest grant was time donated by investigators. They did it for $20 for a pair of case and control, including measuring lipids. Okay? It was passion. It's what we saw yesterday. And the biggest risk factor was lipids, not just LDL, it's apolipoprotein. It is a 300% increase in risk. And it accounts for 50% of the population attributable risk. For those of you who don't know what PAR is, it's the prevalence of a condition multiplied by the excess risk. Half the MIs in this study, and most of these are non-fatal MIs, is due to one single risk factor. The next one is smoking, threefold increase, about 35%. These two together account for the majority of MIs around the world. Social factors matter. Abdominal obesity, hypertension. This is underestimated because in this case-controlled study, you just get self-reported hypertension. Probably it's twice as big as I'll show you in a minute. Diet matters, but we only looked at the fruits and vegetables. I think the role of diet has been exaggerated in cardiovascular disease. It matters, but it's not as big as smoking or hypertension or lipids. Activity matters, and I think we underestimated it. Diabetes matters. Alcohol intake, really very marginal effects. I would say if you want a little bit of a drink, don't feel guilty, but don't feel compelled that you have to take it 3 times a day as a medication. And then, if you put all the risk factors together, the risk increases to 130-fold. 130-fold. You don't need polygenic risk score or any of that fancy stuff. You don't need personalized medicine. The whole world is getting this disease. So every person needs personalized medicine. And then what we did is we looked at the South Asians and said, can these risk factors explain the excess risk in South Asians? And what we did is an unusual analysis called a case-case analysis, where once you adjust for these, what would happen? So we took people who had early disease under the age of 40, because there was good data that South Asians had their MIs early, and you saw before adjustment, the risk in South Asians is about 8% or something, and probability, and here it's about 5.5%. Once you adjust, they're the same. So at least these risk factors largely explain the difference. People ignored stroke, so we studied stroke as well. We did a similar study in 33 countries on about 25,000 people. And again, most of the same risk factors explain 90% of the risk. And here, the number 1 was hypertension, number 2 is smoking, number 3 is abdominal obesity, and here is lipids. So the same 4 things matter for heart disease and stroke, the order may be slightly different. And again, when we looked at population attributable risk globally, about 90% of the risk was predicted by was associated with these 9 or 10 risk factors. Now, I want to give you a little word of caution. 90% is really not 90%. It's got a bit of wobble around it called standard deviation. I also think a case-control study tends to exaggerate these things, and this is non-fatal strokes by and large. There was some people who died later, so fatal strokes, you shouldn't think of it. Same thing, those were non-fatal MIs too. Because the heart failure deaths and other forms of arrhythmic deaths from cardiovascular disease doesn't get counted. Then we set up, we wanted to do a global study. People keep on saying we need a framing, and framing was good in the 1950s. We have to move on. The NIH has moved on. Framing is a great study, taught us a lot, but we need a cohort study. We need cohort studies that are standardized and across the world. So we were able to do it in 27 countries, 5 continents, 1,000 communities, because we were interested in understanding the environmental and the social determinants of cardiovascular disease. And we had all the continents except 2. Australia we couldn't, because it was a desert. And Antarctica we couldn't, because the penguins couldn't sign informed consent. So the first thing that we got was Much to our surprise, risk factors were higher in high-income countries than low-income countries. The narrative is cardiovascular disease is higher in the poor countries. So shouldn't risk factors be higher there? The narrative is that the risk factors are higher in urban areas than rural areas, and that was true in the low-income countries and the middle-income countries, but it was reversed in the high-income countries. So we would expect that in the low and the middle-income countries, cardiovascular disease will be higher in urban areas than rural areas. So this should tell us more in high-income countries, more in urban, and more in But that's not what we saw on clinical events. This shows that major cardiovascular disease was lowest in high-income countries, intermediate in middle-income countries, and highest in the low-income countries. Look at the hazard ratio, 1.6. Now, if somebody from a low-income country went to a high-income country, for the next 20 years, they're going to have the risk that they brought with them. Look at the last data on my first slide, the work from the UK, about a 40% increase in risk in the people. That's what this is. So really, they were just carrying their risk from childhood brought to their new countries. But then the second thing was this line here. Non-major cardiovascular disease like angina, revascularization, they were more common in the rich countries, which means disease was picked up earlier and treated earlier, and you prevented people getting into serious trouble. And if you look at total cardiovascular disease, it's about the same. Fatal cardiovascular disease, look at this marked difference, 600% higher. So if you look at only mortality statistics, that tends to add not only disease incidence, but it also adds to it lack of health care, both acute health care and long-term health care. And this is deaths from any causes down here. Now, a few years back, we published this from the Pure on the first 10,000 deaths worldwide, and 40% of the deaths in this age group, 35 to 70, was cardiovascular disease, 26% was cancer, 8% was respiratory, 9% was injuries. If you're talking of health as opposed to a single disease, we should focus on the common causes of disease and death. The number one cause for hospitalizations in the Pure study, anybody can guess? Take a guess. Alka, you're a smart cookie. Sorry? I can't hear you.
Infectious causes of hospitalization.
Which is the commonest cause of hospitalization?
Say infection.
Infections, okay. Anybody else? Raj, you're even smarter than me, so tell me.
It's not when it's gastrointestinal.
That's right, gastrointestinal problems. So, disease burden is not just mortality. It also includes things like, hospitalizations. It costs money, doctors' visits. So we should start to characterize disease burden in broader terms. Now, if you divide this by low-income countries, middle-income countries, and high-income countries, you see a pattern. In low-income countries, 43% of the deaths, and this is a higher rate of deaths, is cardiovascular. In the high-income countries, it's 23%. This is published in, you can, and it's on our website. Cancers, 15%, 30% in middle-income countries, 55% in the high-income countries we study, which is Canada, Poland, and Sweden. And in the US, cancer hasn't yet overtaken cardiovascular disease, but in many states, it's already happened. I think Lata published a paper on that. And then things like infections. Respiratory and infections is more here compared to that. So we may have to start to think not heart health, but health in South Asians as our motto. But we don't have data from anywhere on the disease incidence, because we have mortality rates from the US, Canada, UK, everywhere. but disease incidence, and these are data that are just hot off the computer about a month ago, which we're preparing for our global meeting in Istanbul, where we have 10-year follow-up and on the first 10,000 deaths. So you will see that the age and sex standardized cardiovascular disease rate is 3.2 in North America and Europe. South Asia, it's double. Okay? But the highest is in Africa, 6.8. And then the others are in between. Look at South America, it's pretty close to North America and China is about that. If you look at cardiovascular disease deaths, 0.6, which is 1 in 5 or 1 in 6 in North America, is fatal. Look at South Asia, 3.3. So if you focus only on death, it'll exaggerate this difference compared to that, but still is real. But this is about 50%. And look at Africa. 2/3 of cardiovascular disease presents fatally. So our problem is, the problem of cardiovascular disease is worse in Africa. People don't think, they all think infectious diseases. MI, 1.8 in North America and Europe, 3.9 there, 1.3 in China, lower. And here is Africa. Stroke, highest in China, next highest out here, and intermediate here, but higher than in North America and Europe. Heart failure, the numbers are small. We only have 1,000 incident cases after 12 years of follow-up. We have to wait another 5 because people are getting older, we'll get more cases. But even early, so heart failure at a young age is seen in Africa. So where is the biggest disease burden in the world? Where is it, guys? Africa. Now, it's high in Asia because we are a lot of people. We breed like rabbits. And Genghis Khan is from Africa. Now, what about in South Asia per se? So these are data on 33,000 people followed for 11 years in the PURE study in South Asia, just published in the European Heart Journal a few months ago by my colleague Phil. And you will see overall causes of death are here. Cardiovascular death, again, about 40% compared to non-cardiovascular disease death. But if you're interested in health, we need to also focus on non-cardiovascular disease. And look at urban. Urban is lower than rural. Although remember in my previous slide, risk factors is higher in urban than rural. It still remains the case. And look at cardiovascular disease again and non-cardiovascular disease. So I've shown you something new. 3 things. Cardiovascular disease rates in countries that originally reported high rates in South Asians have been decreasing markedly. Second, we need to go beyond heart disease. Third, risk factors are not enough because there is a dissociation between risk factors and outcomes, and may be related to environment, access to care, health care, and non-cardiovascular disease should not be ignored because that is a bigger concern as a group. Then again, just like before, this is the causes of the population attributable risk to various conditions. In South Asia for cardiovascular disease, hypertension is the commonest, high non-HDL, diabetes, low education. Earlier on at breakfast, I was speaking to Naveen and he said, what can you do about the social determinants of health? He was very passionate about it. I said, passion's great in the bedroom. So, low education, very, very important thing. And I'm glad you're working on education. I'm sitting next to several people who are supporting education in India and poor countries. Second thing is, household air pollution is a big thing. People talk about outdoor air pollution, and that may be important, but globally, household air pollution. So if you want to do something for India, help them get cleaner cooking methods, cleaner cooking fuel, low activity, and people don't talk about low strength. Remember, people talk about how many did you walk 30 minutes a day, but physical strength is as important as that. So there are 3 things in active exercise or activity: aerobic, which is walking, running, etc., strength, which you need strength to live, and the last one is flexibility. So if you're going to exercise, 1/3 walk, 1/3 lift some weights, 1/3 stretch. Okay, so now all of you get up. All of you get up. Come on, Raj, you too.
Sorry, question.
I said, not a question, I said get up. Stretch.
I was too busy writing notes.
Oh, that's right. Now you can sit down. Now, one or two of you were emerging leaders of the World Heart Federation, weren't you? So what do we do after each thing? We get up, we clap, we stretch. So we'll do that at every meeting and every event of South Asians. Every few minutes after each song by, what is it, that great singer Salim Yusuf or whatever, yesterday, we should have gotten up, not only clapped, gotten up, jumped up, stretched. But now look at that here. You will see, number one is low education. So Naveen, this is your answer. Get people educated. That is your biggest approach to improving health. Low strength, because frailty is related to that, and then the others come. Now this is a paper I'm puzzled about, completely puzzled about, that was published a few months back in PLOS. I put it into my talk, I took it out, put it in, took it out. And last night I was talking to Lata, and she was and Lata is a co-author of it, and she told me she's puzzled about it too, very honest about it. So I wanted to share it with you, so that maybe one of you on reflection will go and read it, and second will reflect on it, and maybe let Lata know or me know how you understand. First, this is all-cause mortality in the United States, okay? And this is non-Hispanic whites. It's higher than Asian Indians. This is foreign-born. This is local-born, US-born. Look at this, 3 to 4 times higher in non-Hispanic whites. Completely different from the narrative we've been hearing all along, and completely different from my own thinking till 10 days ago. Why am I putting it here? It's papers like this that go against the grain that make you think. If every paper showed the same thing, there's no need to read another paper. I'll come back to you. I've got an explanation though. I'll come back to you, Lata, and you get the first question. Now, if you look at this, heart disease goes down. And this is the difference between foreign-born and local-born. Remember what I told you, you bring your circumstances from your home country. And the other thing is neoplasms are lower, Alzheimer's is lower, cerebrovascular disease is lower, respiratory disease and accidents are lower. What this is telling you so how do I interpret it? So I spent 3 hours this morning thinking about this paper. I woke up at 3 and decided to include it. And I said, are these results spurious? I mean, they can't be. This is the US national statistics. The data on the non-Hispanic whites seems to be right. Or are there some methodological glitches or uncontrolled confounding? I don't know. I couldn't find one. Is it real? It may be, because South Asians in the US are younger, and age correction and standardization is probably not when you have marked differences in age structure. I don't know how good it is. They're better educated than the average American population, have higher income, highest income group in the US, access to health care more promptly, lower smoking, better environment and housing, because you're better off, you live in better communities, better social cohesion and networking. All those aunties looking after us will give us jalebi and samosas. So there it is. And we need to understand why disease and mortality rates vary among South Asians in different countries. Within a country, like urban versus rural, completely unpredictable. It isn't your classic risk factors, and why it changes over time. This is the next project, Sunita. You're asking me, what should people do? And many people here, like the colleagues from the UK, from the US, Canada, around the world, can collaborate in trying to understand this. And to understand why things vary by region, you need to have multiple regions. Now, stroke is a neglected condition. Everybody talks about heart disease. So the first thing is into stroke. This is 33 countries. We looked at it. Now in Western Europe and in Eastern Europe, 100% of stroke units is as in North America. But look at South Asia, only about 40%, and Middle East very low, and Africa about 40%. If you look at aspirin, aspirin's given reasonably high. Average is 80% globally for ischemic stroke. These are all MRI documented strokes and interstrokes. Some variations. But look at thrombolytic therapy. Thrombolytic therapy is about, 30% in ischemic strokes for people eligible coming in early and all that kind of thing. Look at South Asia, look at Africa and others. But the just as big disparities in something simple, stroke rehab. Look at Asia, China, Africa, but higher in these countries. And look at survival at 30 days. You will see much higher survival in these countries. Look at South Asia, survival is only about 70%. That means 30% died before they left hospital. And in South America and Africa. And look at independent survival, that is modified Rankin 0 to 2, and alive. In South Asia, only 30% were free. That means 70% either died or had severe disability compared to the other regions of the world. In a sense, stroke is a bigger problem because if it doesn't kill you, it disables you. Now, what is different about the South Asian diet? I think we're so focused. I think we have this obsession with diet. Not only is as somebody said, it's part of our hospitality. Now we're starting to obsess with if it's healthy or not. I would say stop worrying too much. There are only a few simple rules. First, the South Asian diet is generally low in fats, especially saturated fats, because of the so-called vegetarianism. Most of the fats is not coming from proteins. It's low in meats, fruits and vegetables. And we have a paper where we publish that low meat consumption is a risk factor for cardiovascular disease. It's a U-shaped curve. So in the poor countries where you eat less meat, you need to eat some meat. In the rich countries where you eat a lot of meat, you have to reduce your meat. It's not the same. So it's sort of customized recommendations by what you do. And it's high in carbohydrates, especially in that is high glycemic index. Now, actually, I went back to the paper that Ines, Mehta and I wrote in 1992. And I'll read this to you. It says, measures to lower LDL by a low-fat, high-carbohydrate diet are unlikely to benefit South Asians. Remember, by diet, who traditionally consume high-carbohydrate diets. In such persons, preventive strategies should focus less on reduction of dietary cholesterol and saturated fats and more on reducing triglycerides and raising HDL by a combination of regular exercise, weight reduction, and decreased calorie and carbohydrate consumption. 30 years later, after doing research on probably 300,000 people, I think this was right. So, now, where did this hypothesis of reducing saturated fat come from? Well, I won't go into the Ansel Keys story, except to tell you it was based on 10,000 people. Only 5% had diet measured. Only 500 out of the 10,000. Secondly, when you look at their diet methods, they said, we measured diet, but when we think there was an error, we adjusted. They don't tell you if they had a food frequency questionnaire or 24-hour recall, nothing. I've checked their papers. Essentially, the people just wrote down what they thought the diet was. Now, that may be okay, it may not be. And the third thing is, it was highly selective. There was a lot of papers. I would recommend to you, everybody, even non-physician, read a book by Nina Teicholz called Big Fat Surprise. It's edited, it's beautifully written. She's a New York Times bestseller, New York Times reporter, outstanding. She's infuriated the establishment, the diet establishment in the US and the USDA. But anyway, so the idea was, yeah, total fats and saturated fat will increase cholesterol, especially LDL, and lead to chronic heart disease. We published a paper on this on 100,000 people in Lancet Diabetes Metabolism. Andrew Mente is the first author. There is a small increase in LDL, but the LDL that changes is not your bad LDL ApoB. It is a non-ApoB forms. So, and the effects, we published papers, the effects on CHD, as I said, is U-shaped. And it assumes that fats have no other effects on biological systems. So from time immemorial, people have been eating fats from animals. That's how people survived. That this is a meta-analysis or observation studies done by D'Souza, who works with Sonia in the PMJ, and you will see no effect on all-cause mortality, CHD mortality, CVD mortality, CHD, ischemic stroke, or diabetes. That's a totality of the observation study. And right now, there is a big meta-analysis coordinated by Richard Peter, where he got all the 20 studies that had more than 100,000 people with diet data and with 10-year follow-up. And I've seen the results. I can't tell you the results, but it's going to rock the system. So, what about trials? There have been some trials, and when you look at that, the number of cases of CHD in the intervention group was 356, in the control group 346. There's absolutely no basis for the current recommendation for extreme saturated fat reduction. I mean, if you are at the level like the Finns did in eastern Finland in the 1950s or in north of Scotland, that may be the case. And you know, foods are not like tobacco. Tobacco, the right level is 0. Food, the right level is at 0. It's always a sweet spot. And these are data on carbohydrates that we published in the Lancet, that you will see that, again, there's a U-shaped curve. There's a sweet spot around 50% of energy. South Asians consume about 70 to 75% of energy from carbohydrates. And you will see carbohydrates, the epidemiology is stronger. And these are data based on a meta-analysis. We published a glycemic index, the type of carbs you eat, and the pure study was published in the New England Journal. The first author was David Jenkins, that's mentioned here, 2021, do look at it. But 2 other studies had exactly the same result at 25% increase. So cut back your pastas, cut back your refined grains. You can have some whole wheat grains. And remember, the US and AHA guidelines encouraged having pasta to replace fats, all based on the 7-country study. Now, salt, the same story. Every large study has showed that high salt is associated with higher cardiovascular risk. But it also shows that somewhere between 4 and 6 grams of sodium a day is your ideal sodium intake. Below that, there is an association, whether this is causal, I don't know, that lower sodium increases the risk. So I would say avoid high salt, avoid processed food. But you don't have to make yourself miserable by not using any salt. You can use about a teaspoon of salt in your entire day in various forms. Take allowance for salt in the food. Now, I want to come back and end my talk with the basics. The basics is tobacco. These are data from the UK that shows that from 1960 to 2010, over a 50-year period, the mortality rates halved from 42% to 19%. In smokers, it halved from 20% to 4%. So most of that difference came in the smokers who stopped smoking. This is huge. So number one message to South Asians is stop smoking if you smoke, and thankfully people don't. Number 2 message is check your lipids, and I would even say do something about it. But let's go about it. So what is clear is avoid tobacco, lower LDL, lower blood pressure, and the 3 together can likely reduce cardiovascular disease by 75%. Not peanuts, 75%. So in whom should we interfere? there is the entire Western health systems has been on risk stratification. I want to tell you, it doesn't work. And because, look at this. So this is the pure study. No doubt that if you had prior cardiovascular disease, you have 21% rate, 21 per 1,000 over 10 years. No prior disease, 6%. Okay. But there are many more people without cardiovascular disease in the population. So if you look at where the events came from, the majority, 80% of the events came from people without cardiovascular disease. Prior. So primary prevention is very important. It is even more important than secondary prevention. You save more lives, and without primary prevention, we aren't going to control this epidemic. And there is an artificial distinction between primary and secondary prevention. Some people who have not had cardiovascular disease have just as high a risk as those who had a cardiovascular event and don't have heart failure or low ejection fraction. And the distinction between absolute risk of individual and the risk of a population is different. The absolute risk of an individual comes from individual risk factors. The absolute risk of a population comes from the distribution of the whole population. We need to do both. And to prevent the majority of cardiovascular disease events and deaths, primary prevention is essential. I've come to this realization after doing 25 years of secondary prevention trials. And now I believe primary prevention is very important. So we now need to have better methods of detecting and controlling risk factors. These are the global data on control of hypertension. Here is high-income countries. 50% of those who have hypertension are there. 48% are treated, so most are treated, but they're treated poorly. Only 16% are treated well. And the main reason is they're given one drug at a time, not multiple drugs. Upper middle income countries, it is little better, not little better, but the same. Low middle income countries 10%, low income countries 8%. Here is a risk factors we've known about for 50 years. We must at least have 10 drugs that are inexpensive, that work and are safe. What a miserable scorecard. If your kid came home with the scorecard, you'd say fail, fail, fail. Now, this is again a recent study by another group where they surveyed 41 countries. Here are data in secondary prevention. Statin and aspirin use only 20%. I mean, that's not great. Here's blood pressure, only 30% are receiving. Primary prevention, lower for these, and down here. Part of the problem is most people get no drugs, and those who get drugs, they only get one drug. So we under-detect, reluctant to treat, and when we treat, we under-treat. Now, so we need a different method. The standard medical system based on doctors has failed. So we started studies in India called, this is SPREC, secondary prevention, using community health workers after acute coronary syndrome. The first author of this is Dennis Xavier, published in Lancet Diabetes Endocrinology. And we just wanted two simple things. Can we get people to modify their diet if a community health worker told them to, in their homes, and adhere to evidence-based medicine? And about 700 people were randomized, and you can see there was a modest increase in medications, but much more is a big increase in adherence. And if you look at blood pressure dropped by 4 millimeters, systolic, BMI slightly decreased, waist decreased. So there was an effect of these people. And tobacco, 85% of smokers stopped compared to 50%, and physical activity improved 89% versus 60%, and diet score improved. And if you look at HbA1c, that too, 8 versus 7.1. This is like giving one drug to people. That's pretty impressive. And lipids, not much of a change. HDL increased a bit. That fits in with the idea they were more active. Now, Then comes the concept of the poly pill, which I've been working on for 20 years. And the idea is to use 2 blood pressure lowering drugs plus a statin with plus or minus aspirin in a single pill at low doses with no dose titration. Very easy. And it should, in theory, reduce cardiovascular disease by 2/3 or 3/4. By using low doses, you'll get about 80% of the effects on risk factors, but you get practically no side effects. That is the key. And now this is a meta-analysis of 3 large primary prevention trials, followed for 18,000 people, followed for 5 years. 2 we did, 1 was done in Iran. You will see with the yellow is the effects without aspirin, and the turquoise is with aspirin. And you will see there's nearly a 45 to 50% effect with aspirin, about a 33% effect without aspirin. And the same thing is true on MR, stroke, CVD. And because it prevents revascularization, it saves money. So it's cost neutral and saves money. And who would you give it to? Clearly to people with vascular disease, people with diabetes, people with hypertension, and perhaps people over 55 or 60 years. This was published in The Lancet, you can read it there. Now, working with people at IHME, the Global Burden of Disease, David Watkins made some projecting. If we say that the uptake of polypill by the year 2030, 8 years or 10 years from now, is only 50%, you will see it will prevent 2 million cardiovascular disease deaths a year and 3 times as many cardiovascular disease events a year. And if it gets to 80%, which is, aspirational, probably never happen, and say by 2050, we will be twice that much. This is big time, but it's boring. You know, give me one pill, everything in one pill, no dose titration, measuring nothing. Come on, you can't build much, can you? So, but it's boring, but it saves lives. It's not personalized, but it saves lives. And a famous cardiologist, even last week, when a paper in the New England Journal came out saying, it's a bad idea. So my response is a bad idea to save lives. I agree with you, Steve. So here is how can you now deliver it? These are my last 3 slides or 4 slides. You need a program. All of these are bits and pieces. Now you saw that the community health worker works, but only a modest effect. Can we use the polypill delivered by the community health worker at screening in people's homes to improve things? So this is a study we did in Malaysia and in Colombia, 2 parts of the world, middle income countries. 30 villages, 30 communities, half urban, half rural. And what we found is first we identified the contextual barriers, and then we trained the community health workers or non-physician health workers to overcome it. Then we developed a community-based comprehensive intervention program based on step 1. And then we did a randomized trial of these 30 communities, about 1,200 people. I'll skip that. And so we took people over the age of 50 years with new hypertension or uncontrolled hypertension. Those are the people. They were all identified in the community, either in the home or they were invited to a screening visit in the local school. And first we tested how good were the non-physicians compared to physicians. Their assessment of cardiovascular risk was the same. Their contraindication to cardiovascular disease medications were the same. Their treatment medications was pretty much close. In addition to that, we said, you need somebody to support the people who are going to take medicines. Just like a spouse nags the other spouse. Did you take your medicine today? Did you check your blood pressure today? So you need a treatment support. It could be a family member, it could be a friend. And we trained them as well. And the training didn't take much, just about half an hour at home. And in 94% of the visits were done by the community health workers, and in 74% of the visits, the supporter or the nagger was there. And this is what we found. First, the framing and risk score was reduced by twice as much in the intervention group compared to the control. Just by the strategy, and they could give statins under using an algorithm. and give blood pressure medicines, you'll see half a millimole difference, or what is that in American units, about 20 units, 20 milligrams, but that's 18 milligrams. Systolic blood pressure dropped markedly. Look at that, 11 millimeters. And the proportion with blood pressure control was 69% in the intervention group, far different from that 15% I showed you earlier in one of the earlier slides, and that was improved by 40%. So this works, and it works in a big way. This change in Framingham risk score equates a 50% reduction in risk in cardiovascular disease in the community. So I'll conclude now. I know I've been speaking a long time. First, the differences in incidence and mortality from MI and stroke between South Asians and other groups varies by location and over time. Because it varies, it means it's modifiable. It's not fixed. And because of that, it is highly likely that most of the difference is not genetic. And in fact, I had slides from the UK, the CVD consortium, that shows they couldn't explain it by genes after GWAS. And in general, most risk factors in South Asians and other ethnic groups have similar impact on CVD. That means our approach to CVD control, by and large, should be similar, except for some differences in behaviors which are culturally determined, because then you take the cultural context into that. And environment, like if you go to India, tons of air pollution, cooking methods. Here practically nobody uses wood or coal to cook. So you don't worry about it, but in India or Pakistan or in Africa, you worry about that. But we need a systems-based approach. We need a systems-based approach to improving both primary and secondary prevention, and the non-physician health worker and the polypill have important roles in that. And we need to also explore the role of the environment, air quality, temperature, and of these two, I think temperature is more important with climate change. We have data showing a 1% increase in temperature from an ambient temperature, 20%, equates a 2% increase in mortality. Imagine that across the world, or 4% actually. So my conclusion is premature cardiovascular disease can be halved in the next 25 years globally by controlling common risk factors such as tobacco, LDL and blood pressure, and through a health systems approach for better primary and secondary prevention after both MI and stroke, both of them. Okay, and who works on air pollution? She's from Australia here, up there, praying from India. So that's the core team that's working on it. And this is pure collaborators that came for a meeting in Hamilton a few years back. We're having a post-pandemic meeting next month in Istanbul. So really, these are the people that did the work. You can see people of all different hues, shapes, sizes, but nobody obese actually. So that's good. Thank you very much for being patient listening.